So, Chapter 7 Anatomy, Physiology, and Medical Terminology. Why do you guys think understanding A and P is important for us? Yeah, we need to understand how the body and the mind works, how our body systems work. Why is it important to have an understanding of how they work normally? Yeah, absolutely. So, in order for us to, and generally when we go and deal with emergency patients, when we deal with trauma patients, do they call us because their body systems are working correctly or because something's going on with them? Generally, something's going wrong with them, right? So, in order for us to understand how to treat what is wrong, we have to understand what is right before we can treat wrong. Okay. So, our AMP kind of builds that foundation of us understanding how our body systems work, how we process, and how things happen for us in order to when we get that call, we can understand what is wrong with them and how to treat them to get them back to normal. As an introduction, the knowledge of how the human body works is paramount for proper patient care. And understanding correct terminology allows all of us to communicate on the same language. So if I tell you that the patient has a large hematoma to the occipital region of their head, does that mean anything to you guys right now? Maybe not, right? Or if I tell you that they have a fracture to the proximal portion of their tibia, does that mean anything to you now? Maybe not. So this is why we have to understand our A and P and our terminology. So as I describe these things to you guys, we understand what is going on. Okay. Plain English is what we prefer to say, right? So if I tell you he has a large bump to the back of his head, that is the same thing as that hematoma to the occipital region of his head. If I tell you that he has a fracture to his tib fib just below his knee, that is that proximal tib fib, right? So when we're talking here, it's going to be plain English, but as I'm typing up my report, I'm going to use medical terminology and scientific terms because those are all legal documents that we're using. Okay. So our objectives is we're going to define what anatomy and physiology is. We'll talk about the anatomical positions. We'll talk about some anatomical planes, our body systems and how they function. And then also we'll discuss some medical terminology. I will watch a video at the end of the lecture to drive home some of those concepts. So anatomy is the structures of the body or how the body is made. And physiology is the functions of the living body and all of its parts or how the body works. So anatomy is the structures and physiology is how they work together. And then our terminology assists us in describing correctly how to speak to each other and get each other on the same page to describe patients' illnesses and or injuries. As far as our anatomical positions, we have something called supine, we have prone, we have the lateral recumbents, both left and right. We have Fowlers, semi-Fowlers, Trendelenburg, and then the shock position. So how many of us sleep on our bellies at night? I'm a belly sleeper. Okay. So when we sleep on our bellies and we're face down, that's called prone. How many of us sleep on our backs at night? You guys are all sociopaths. Okay. The only people that sleep on their backs are vampires. But when you sleep on your back, that's called supine. So when I'm lying flat on my back, I'm supine. And when I'm face down on the ground, I am prone. I have my lateral recumbents. So if I lay on my right side, that's my right lateral recumbent. And if I lay on my left side, that is my left lateral recumbent. The left lateral recumbent is also known as the recovery position. We have Fowlers and semi-Fowlers. How many of us like driving with a little bit of a gangster lean in our cars, right? And no, Leif does, right? Noah admitted it. No one else is going to admit it because I'm making fun of you guys right now. But when we have that lean back, that's called semi-Fowlers versus how we're sitting upright in our chairs right now, how we're at that 90-degree angle at our hips. That is called a Fowler's position or a high Fowler's position. Okay, so we can go from high Fowlers or Fowlers, and as we lean our patient back, that becomes a semi-Fowler's position. We have something called Trendelenburg. Trendelenburg is this one right here. So your Trendelenburg is when your patient's legs and or ankles are placed above their head. At one point in time, this was used for patients in shock, and the idea was the blood would return from their legs into their core and help provide better circulation. Through time and through studies, we've learned that when we place a patient's legs or raise a patient's legs, their abdominal contents apply pressure on the diaphragm, which is the muscle that helps us breathe or makes us breathe. And that pressure is causing difficulty breathing or causing pressure in that thoracic cavity. So we no longer do Trendelenburg for our shock patients. Okay. If you go on scene and you see someone whose legs are raised, don't yell at the staff who did that. Just say, thank you so much for helping. And we're going to lower that patient's legs back down. And then our shock position is supine. So when we lie our patient flat, that is supine, and that is our shock position, right? So when we clot our patients treating for shock, what is clot? Yeah, cover, lay supine, oxygenate, and transport. That lay supine is our shock position. Yes, ma'am. It's not that it's going out of vogue. We shouldn't do it, but people still do it all of the time. So it's common practice, but this is why we have these teaching moments. This is why we talk about it in school. So when you guys get to the field a few months from now, and then as you guys are EMTs over the years, we're educating all of this stuff out in a way. Yes, sir. The Trendelenburg, I think for certain procedures, you can do it. Also, yeah, it would be certain medical procedures, but I'm thinking off the top of my head when I would lift them, I really don't, I don't know. I'd have to double check on like why we would do it. Good question. Yes, sir. Semi-Fowlers when we're gangster leaning in our car. Yep. When we're not quite 90 and we're not quite supine. So anywhere in between lying flat on your back and sitting straight up is your semi-Fowlers. As far as our anatomical planes, we have our sagittal, frontal, and coronal, and our transverse or horizontal planes. So my sagittal plane, how many of us have seen Resident Evil, the first one, where they go through that tunnel and they have all the laser beams and they start cutting people into pieces? So some of us have, some of us haven't. Some of us won't admit that we have, right? So if I take a laser beam and I cut myself directly in half from my nose to my sternum, that right there is called my sagittal plane. I divide the body into left and right halves. Then I have my frontal or coronal plane. If I take that same laser beam, I cut myself down my ear, across my rib cage, down my hip to my ankles. That is my frontal and coronal planes. That divides my body into a front and a back. And then I have a transverse or horizontal plane. This is what, if I were to take that laser beam and cut myself at the waist, I can cut myself into a top and bottom half. So if we look at the photo, my sagittal cuts the body in half down the center. My frontal cuts the body down the ear on the side of the body through the pelvis and the ankle. And then my transverse cuts across the waist into a top and bottom, or upper and lower half. And then we have a few other terminologies. So we have something called a midline, right? The midline is the same thing as that sagittal plane. So the midline goes down my nose, down the middle of my sternum, and that divides my body into my left and right halves. My midline, right? The middle. I have a mid axillary line. So when we listen to our lung sounds on the rib cage, right on this side under the armpit, or that line that goes from my ear down through my armpit, my pelvis, and then into my ankle, that is my mid axillary line. And I have a transverse line, which is directly through the waist, and that divides my body into that upper and lower portion, or my superior and inferior portion of my body. Some other descriptive terms is we have anterior and posterior. So anterior is the front of my body. Posterior is the back of my body. I also have dorsal and ventral. So dolphins have what on their backs? Dorsal fin. So dorsal is the back of someone, and then ventral is the front of that person. I have superior and inferior. So superior is above, inferior is below. So if we're talking some terminology, my chin is superior to my pelvis. My sternum is inferior to my nose. Okay, so superior is above and inferior is below. I have medial and lateral. What does medial sound like? Medium or middle, right? So medial, middle. So that's towards the midline. If we're watching rugby or football and I throw the ball out to my side, what is that called? A lateral, right? So lateral is away from the midline. Okay, so if I'm holding my arm out this way, as I move towards my body, that's medial. And as I move away from my body, that's lateral. I have proximal and distal. So what does proximal sound like? Proximity, right? So proximity is closer to my body, and distal sounds like distance. So distal is further away. I have my right and my left. This is the patient's right and left. So as I'm looking at my patient here and I'm like, hey, miss, can you lift your right hand? It should be that one, right? So don't confuse my right with their right. Oftentimes I'm like, it was on their right side, okay? So be aware of those little intricacies. We have mid-clavicular and mid-axillary. So I have my midline, which goes down my nose and my sternum. Then I have mid-clavicular, so the middle of my clavicle. If I were to draw an imaginary line downward, oftentimes this is like the nipple line is mid-clavicular. And then this line on the side of my rib cage is called my mid-axillary. I have my plantar and palmar. What does palm sound like? Or palmar sounds like palm, right? So palmar is the inside of my hand, and plantar is the bottom of my foot. Okay. Any questions on these terminology here? Yes, sir. Yeah. So dorsal versus ventral. So dorsal, think dorsal fin. Dorsal fins are on the back of animals. Ventral is going to be on the front portion of that person or that animal. So let's just have this mental jog, right? So my wrist compared to my shoulder is what? Distal, right? So it is distal, or what is another word that we can describe that with? Lateral, right? So my wrist is distal to my shoulder, but it's also lateral because it's away, okay? Now, if we talk about my elbow, compared to my wrist would be what? Proximal or medial. So it's proximal because it's in proximity or closer to my midline, or it's also medial because it's coming towards my midline. Okay. What is this line called down my rib cage or down the side of my rib cage? Mid-axillary. What do we listen for in that mid-axillary line? Lung sounds, right? So these are all just kind of things that we're tying in together. If I'm talking about my toes are what compared to my pelvis? Inferior, right? Because they're below. And then my sternum would be what to my pelvis? Superior, because it's above. So we're gonna drive some of this stuff home in understanding. Okay. If I'm lying flat on my back, what is that called? And if I'm lying face down, what is that called? Prone. Okay. And if I'm gangster leaning, what are we sitting like? Semi-Fowlers. And you guys are all sitting how? In a Fowler's position. Okay. So these are all things. So if I tell you we arrived on scene to a private residence to find an 86-year-old female lying prone, how was she presented? Face down. Okay. So all of these things, when we talk about that general impression, age, sex, position, level of distress, any major hemorrhaging, and with that position, we're going to start using these anatomical positions and terminology. Our abdominal quadrants, it's divided into 4 quadrants. We have a right upper quadrant, a right lower quadrant, a left upper quadrant, and a left lower quadrant. Why do you think it's important to understand what is in each of the quadrants? So understanding solid versus hollow organs is one part. Yeah. So if I was hit by something in this left upper quadrant, if I understand what's in that quadrant, I can think about what organs might be under there. Or if I'm complaining of right lower abdominal pain, I can understand what organs are there, which helps me decide what could be wrong or figure out what could be wrong. So in our right upper quadrants, we have the majority of the liver, we have our right kidney, our colon, a small portion of our pancreas, the gallbladder, and the small intestines. In the right lower quadrant, we have our colon, small intestines, right ureter, we have our appendix, and in females, we have the right ovaries and the right fallopian tube. In our left upper quadrant, we have a small portion of the liver, we have the spleen, our left kidney, our stomach, colon, the majority of our pancreas, and our small intestine. And in our left lower quadrant, we have our colon, the small intestine, the left ureter, and in females, the left ovary and left fallopian tube. As far as our body systems, we have the musculoskeletal system, the respiratory system, the circulatory system, the nervous system, the endocrine, integumentary, digestive, and urinary systems. We're going to dive a little bit deeper into all of these aspects. Okay. So as far as our musculoskeletal system, this is our bone and our framework. What do you think is important about our musculoskeletal system, or what does it provide to us for us as human beings? It allows us to move. What else? Protection. Anything else that we can think of? It also produces our blood cells, right? Our bones create our blood cells. Okay. So our musculoskeletal system is a bony framework that consists of tendons, ligaments, muscles, and other connective tissue. It gives our body shape, It protects our body. It protects our vital organs, allows us to move, and it stores minerals and produces blood cells. How many of us have seen like a broken bone and it's just like, whop, just flops, right? So without our skeletal system, without the muscles and what we have, we'd be like gelatinous goops of just like sliding across the floor. Okay. Also, too, what is inside or what does my rib cage protect? My lungs, my heart, my great vessels, right? So all of these are designed to protect our vital organs so we don't get injured and die. Our skeletal system has six main components. It consists of our skull, our spinal column, our thorax or rib cage, our pelvis, and our upper and lower extremities. We have our joints. Our joints provide motion for us. It creates flexion, extension, adduction, circumduction, pronation, and supination. So as far as flexion is when we flex our bodies and they move upwards and towards our body. Okay, so when we do bicep curls, that's flexion. As I move my wrist downward and straighten my arm, that's extension. I have abduction and adduction. Adduction is when our body is moving towards our midline. So as my arm's coming in towards my hips, that's adduction. And when we think of abduction, I think about the cows in Missouri who get abducted by aliens. So it moves away from us or gets pulled forward. We have circumduction. So circumduction is when I move my arm like this, how it can rotate in a full circle. That is circumduction. I have pronation, which is bringing downward this way. And supination is when I come upward this way. My different joints, I have a ball and socket joint. What are some examples of ball and socket joints that you guys can think of? Not the elbow, the shoulder, right? Or what else? And my hip, right? So the head of my femur into my pelvis or the head of my humerus into my shoulder, those are ball and socket joints. I have hinge joints. My hinge joints are like my elbows. It's like a hinge, right? So as I open a door, it hinges. We have our pivots. So my pivot is like my skull, where I can move left and right. So it's pivoting, gliding. So inside our hands and our feet, we have a bunch of metatarsals and metacarpals. Those are a bunch of small bones that are set together that create some or slight sliding. So it's not just one big bone that can break, they can slide off of each other. We have saddle joints. My saddle joints are like my fingers, how they sit in little saddles, and I'm able to bend my fingers. I also have my condyloid joints. Your condyloids, I believe, are going to be like your wrist, where it can come into a full circle. So it has full range of motion up and down and circular. So my condyloids. I have my tendons and my ligaments. My tendons connect muscle to bone, and my ligaments attach bone to bone. The way that I remember this is ligaments are BLB, bone, ligament, bone. If I know what a ligament is, as a byproduct, I know what a tendon is. So tendons are muscle to bone. So ligaments, BLB, bone, ligament, bone, tendons, muscle to bone. As far as our different types of muscles, I have skeletal muscle, cardiac muscle, and smooth muscle. My skeletal muscle is known as a voluntary muscle. What does that mean to you guys when I say voluntary muscle? Yeah, I can physically make it move. So all of my exterior muscles, as I'm working out, as I'm running, as I'm thinking about movement and motion, those are all voluntary skeletal muscles. They're controlled by our nervous system, and they give our body mass and shape and size. And then I have my cardiac muscle. Where do you guys think cardiac muscle is? In our heart, right? So my cardiac muscle is in my heart. It has the ability to generate its own impulses, and it has its own constant supply of blood from the coronary arteries. So with it creating its own impulses, when was the last time, if ever, have you told your heart to beat? Never. It just does its own thing. It beats how it wants to beat. Hopefully it beats regularly and strongly, but it has its own impulse to where it's its own pacemaker and does what it's supposed to every single time throughout time. And then we have our smooth muscles. These are involuntary, meaning that they perform automatically. So this is going to be most of our organs, our GI tracts. We have our respiratory systems, our digestive tracts, and our vasculature or our vessels. Let me ask you this. When's the last time you thought to breathe before right now? We don't, right? Your respiratory tract is one of these like in-betweeners. It is completely involuntary. So it does its own thing whenever it needs to. But if we need to take a deep breath, we can take a deep breath, or we can try to slow our breathing down if we have to. But it's an involuntary smooth muscle. Our respiratory system, the basic functions of our respiratory system is for respiration, ventilation, oxygenation, and the removal of carbon dioxide, and assisting in maintaining our acid-base balance or allowing our body to stay in homeostasis. So respiration is the process of moving oxygen and carbon dioxide across membranes in and out of the alveoli, capillaries, and cells. Oxygenation is the transfer of oxygen from higher concentrations to lower concentrations. That process of moving from high concentrations to low concentrations is called diffusion. And then we have ventilation, which is the mechanical process of moving air in and out of our lungs. Exhalation removes excess carbon dioxide from our systems, which helps reduce the acid load in our body. So let me ask you guys this. Our nasal cannulas and our non-rebreathers, do they provide oxygenation or ventilation? Oxygenation. So they're not increasing that movement of air in and out of my lungs, but what we're doing is increasing the percentage of oxygen that we're inhaling. Can anyone tell me how much or what percentage of oxygen is in normal atmospheric air? What was that? Okay. 21%, right? So that we're breathing, and some of you are like, what the heck? I've never heard of this. It's okay. This is why we're talking about it, okay? I don't expect you to know all of the stuff I'm throwing at you. This is why we're having this discussion. Okay. Normal atmospheric air that we're breathing in and out right now is 21%. The oxygen in our D tanks or in our oxygen tanks, what percentage do you think that's at? 100%. Okay. So if someone has low oxygen levels and I put them on a nasal cannula, I don't really give them 100% oxygen, but through them inhaling, they're getting anywhere between 28 and 32% oxygen. So if I'm increasing that percentage, I'm increasing my oxygenation. Okay. Do you guys, or can you guys name a tool that we have to assist with ventilation? A BVM, right? So our bag valve mask, as I compress my bag valve mask, I'm pushing air into that patient's airway, into their lungs, and I'm seeing that chest rise and fall. That is now ventilating those patients. Okay. Can or do our BVMs do oxygenation and ventilation? Absolutely, right? So if we attach our BVM to an oxygen source, we're both oxygenating and ventilating our patient. So structures of the airway. Our airway is a passage that air travels from outside of our bodies, inside of our bodies, into our lungs, and then through or into the rest of our bodies. Our airway is divided into two portions. We have an upper airway and a lower airway. As far as the upper airway goes, we have our nose or our nares, our mouth or oral cavities. We have our pharynx, which consists of our nasopharynx, oral pharynx, and laryngopharynx. Our larynx, which is also known as our voice box. We have our epiglottis. The epiglottis is this leaf-like flap that covers the trachea when we're eating and drinking fluids or water. Okay. Let me ask you this. Why is the epiglottis or having that flap extremely important? Absolutely. You're 100% correct, right? So that epiglottis, that flap closes over my trachea. So my food goes into my esophagus, which then goes into my stomach, right? Have any of us drink water and start choking? Oh my gosh, I'm dying. Or like wrong pipe. That means that air or fluid or whatever that you're trying to consume either got into or under that epiglottis, and that's why you're choking. Okay, so that epiglottis protects our airway from food or foreign objects or foreign bodies from entering our lungs. Your upper airway ends at your cricoid cartilage. Your cricoid cartilage is your Adam's apple right here. So everyone touch your Adam's apple. Everything superior to the Adam's apple is your upper airway. Everything inferior from your Adam's apple or cricoid membrane, cricoid cartilage, is going to be your lower airway. Next, we have our lower airway. So our lower airway is from that cricoid cartilage, inferior or downward. The way that I like describing the lower airway is it's an upside down tree. Okay. So you have your trachea, your bronchi, your bronchioles, your alveoli, and then your lungs. So if we're going to draw our lower airway, the upside down tree is I have my trunk. That is my trachea. And then it splits off into my left and right bronchi. Can you guys all see the green from across the room? Or is that a little faded? Pretty faded. Let me grab a different color. That better? Okay. So I have my trachea, which is my main trunk to my tree. Then I have my bronchi, which are my right and left bronchi. So it splits off into two. This bifurcation, or where it splits, is known as the carina. Carina. I've heard it pronounced carina and carina. When I was taught it, it was the carina. If you pronounce it one way or the other, you're not going to hurt my feelings. Okay. So we have our trachea, our right and left bronchi. From our bronchi, it's going to split into something called bronchioles. Bronchioles are slightly smaller airways. So we'll split into bronchioles. So these are all of our smaller branches coming off of our main two branches, or our bronchioles. Next, it is going to go into our alveoli. The alveoli are these grape-like sacs or little kind of balloons that open and close as we inhale, which is going to have that oxygen transfer. In your alveoli, if we draw this over here, your alveoli look like this. As I inhale, I'm going to have oxygen come into my alveoli. And then around here, I have a capillary, which has red blood cells. And this oxygen transfers from high concentrations to low concentrations from inside my alveoli onto my red blood cells and then back into my body. Also, carbon monoxide, CO2, carbon dioxide, is then hopping off of my red blood cells and my bloodstream into the alveoli. And as I exhale, I'm breathing out my CO2. Does anyone remember what it's called when we go from high concentrations to low concentration? It starts with a D, diffusion, right? So in order for this to happen from high concentrations to low concentrations, it's diffusing or diffusion onto the red blood cells and then into the rest of my body. There's something called surfactant. Surfactant is like a lubrication or a lubricant that keeps my alveoli nice and lubricated so they can expand and contract without them bursting or becoming damaged. Has anyone found a rubber band outside and you try to shoot it at one of your friends? What happens to that rubber band? It breaks, right? So it's dried out and it snaps. No different than our alveoli without that surfactant. It's going to try to stretch and break and or burst. Inside of our lungs, we have a couple different layers of serous tissue. The visceral pleura covers the outside of our lungs, and the parietal pleura covers the inside of our chest wall. So we're going to have our lungs here, visceral pleura, and then parietal pleura, and then chest wall. Okay, so as that's what's going on inside of my thoracic cavity. We also have this giant muscle that comes across the bottom of my rib cage. This is called my diaphragm. My diaphragm helps assist and control my breathing. So as I inhale, my diaphragm contracts and expands, which is then allowing air to be sucked inside of my thoracic cavity. And as I exhale, my diaphragm is going to relax and then push that air outward. So when I breathe in, that's called negative pressure. So if we can imagine, how many of us have used either a bike pump or like a balloon pump? So as I have my pump imaginary in my hand and I pull down my piston, it's creating negative pressure to draw air inside of that canister, right? So that's my inhalation. And as I push that piston up, it's going to create positive pressure to push that air out. That piston, as I draw it down, is my diaphragm pulling air into my lungs. And as I exhale, my diaphragm relaxes and pushes that air out of my lungs. Okay. Does that kind of make sense? All right. So that piston pump is a little bro sciencey to understand the concept behind it. But as my diaphragm expands, air gets pulled in, negative pressure. As I exhale, my diaphragm relaxes, positive pressure to push out all that CO2 and byproduct. Okay. Any questions on that one? Okay. The pediatric airway. So for our pediatric patients, things to consider is their mouths and noses are smaller. So with them having smaller noses and mouth, they're moving less air. Also, their airways are more prone to obstruction. So they're more likely to put something in their mouths and get them occluded. Their tongues are disproportionately larger than the rest of their bodies. So they have these massive heads and huge tongues, which can potentially be an airway obstruction. Also, too, since their heads are bigger, if I lie them flat, they're going to do something like this, and that can potentially crimp or close their airway. So if we have a pediatric patient supine on their back, we want to pad their shoulders, and that puts their airway into alignment. Also, their tracheas or their airways are described as either being conical or hourglass shaped. So as a cone, it's bigger in the top and slowly gets smaller towards the bottom. With it being smaller in the bottom, what am I concerned with happening with that airway? Blockage, right? Things getting stuck or that obstruction. Okay, so they're either described as conical or hourglass. And we're worried about those obstructions. Okay. Also, there's called diaphragmatic breathers. So they use their diaphragms to breathe much more because their chest walls aren't as developed. They don't have big, strong chest muscles like all of us. So mechanics of ventilation, we discussed this with that pump explanation and our diaphragm expanding and contracting. Okay. So as my diaphragm expands or as it flexes, what is happening? Air is being pulled in or pushed out? Pulled in. So if air is being pulled into my thoracic cavity, it's creating a negative pressure in my thoracic cavity. As I exhale, that diaphragm relaxes. And when it relaxes, what is that doing? Pushing air or pushing CO2 outward, right? So as my diaphragm is moving downward, I'm pulling air in with my inspiration. With my exhalation, my diaphragm is relaxing and pushing that air out. We have something called our phrenic nerve. So in our cervical spine, my C3, 4, and 5 is how my brain speaks to my diaphragm. So if I have an injury to that portion of my neck, I can knock out my respiratory drive. So adequate versus inadequate breathing. Our respiratory rate plus our tidal volume equals adequate breathing. So all of us right now, our respiratory rates are good. We're moving in and out enough air. So we all have adequate breathing. What are some things or some descriptions of inadequate breathing that you guys can come up with or can think of? What was that? Shallow breathing, right? So too shallow breathing could potentially be an adequate version of breathing. What else, guys? Rapid breathing, right? So if I'm breathing too fast, so if we think about that rate, it can be either too fast or too slow. Okay. So I can have too shallow breathing. Can I have too deep breathing? Potentially too deep breathing. I can have too fast breathing. I can have too slow breathing. I can have diminished or absent lung sounds. I can also have different or abnormal breath sounds because of some pre existing medical condition. I could be moving too little, or I don't think we would be moving too much air, but I can be moving too little air. I can have bluish or gray skin. If I have bluish coloring to my lips, do we know what that's called? Cyanosis. So, cyanosis is a sign of hypoxia or low oxygen levels. We can have some head bobbing, and there's something called agonal respirations. Agonal respirations is also known as guppy breathing. You'll have a patient, and this is almost like a pericardiac arrest type breathing. Most patients with agonal breathing tend to be very close to coding or going into cardiac arrest. And it's just this gasping respiration, and it's going to eventually lead to cardiac arrest. Okay. Our circulatory system is composed of our hearts, our blood vessels, and the blood. What this does is it's our body's like transportation or highway to move blood throughout our bodies. It's a closed system. If my circulatory system becomes an open system, what is happening to the patient? They're bleeding out, right? So they're bleeding. So this is a closed system, and blood brings oxygen, nutrients, and other chemical elements to the cells, and it also assists in getting rid of waste product and byproducts. So the functions of the circulatory system is that it provides cellular perfusion for oxygen nutrients, meaning that it assists in that transportation and delivery of oxygen nutrients. It removes carbon dioxide and waste products from our body. It transports blood cells to the alveoli for gas exchange so that oxygen can go from our alveoli onto our cells and then into our system. It serves as a reservoir to house our blood. So that's where we hold all of our blood. It assists in buffering acid and base balance so we can maintain that homeostasis or proper pH levels. It delivers immune system or immune cells to help defend our body from illnesses. And then also it contains our clotting factors to help clot if we start bleeding. the basic anatomy of our heart consists of 4 chambers. We have 2 atria and 2 ventricles. It has a number of valves. We have our tricuspid valve, our pulmonary valve, our bicuspid or mitral valve, and also our aortic valve. As far as blood flow through the heart, we have our superior and inferior vena cava bring deoxygenated blood into our right atrium. From the right atrium, it goes through our tricuspid valve into our right ventricle. The right ventricle will push blood through our pulmonic or our pulmonary valve into our pulmonary artery, which carries deoxygenated blood into our lungs or our pulmonary circuit. From the lungs, blood will return to the heart from the pulmonary artery into the right atrium. From the pulmonary artery into the left atrium. From the left atrium through the mitral or bicuspid valve into the left ventricle. From the left ventricle through the aortic valve into the aorta, through the aortic arch, and to the rest of our body. Couple of things to think about or to remember is the atrium are on the top portion of our heart. The ventricles are on the bottom portion of our heart. This right side is our deoxygenated side. The left side is our oxygenated side. We have our pulmonary arteries and our pulmonary veins. Pulmonary artery is the only artery in the body that carries deoxygenated blood. And our pulmonary vein is the only vein in our body that carries oxygenated blood. We'll continue working on this one. So as a recap, superior and inferior vena cava into the right atrium. From the right atrium through the tricuspid valve into the right ventricle. From the right ventricle to the pulmonary artery, which is the only artery that carries deoxygenated blood into the lungs, through the pulmonary circuit or our lungs. So now it's oxygenated. The blood returns through the pulmonary vein into our left atrium. From our left atrium through the mitral or bicuspid valve into the left ventricle. From the left ventricle through the aortic valve into the aorta and to the rest of our body. So as far as our blood vessels themselves, we have arteries, arterioles, capillaries, venules, and our veins. The way that I like describing these is our arteries and our veins are our major highways or the freeways of our body system. So when we think of a freeway, are there lots of cars or a little bit of cars on our freeways generally? Lots of cars, right? Lots of cars. Our freeways are designed to move lots of cars over distance over a fairly quick time, okay? So our aorta, our coronary arteries, our carotid, femoral, dorsalis pedis, posterior tibia, our brachial, radial, and pulmonary arteries. Those are our main arteries. As far as our veins, one of our main or the main vein that we have is our vena cava. We have inferior and superior vena cavas, and then also our pulmonary veins. So if we go back to this major highway analogy, imagine that my arteries are like my 15 north, okay? So my arteries are my 15 north. When I exit the freeway, I get onto something called a surface street. That surface street is going to be my arterioles. And then when I get into my neighborhoods, because neighborhood roads are much smaller, think of those as my capillaries. Then I need to get back to school or back to where I'm going. So I hop back onto my surface streets or my venules. Then I hop onto my 15 south, which is my vein. And that's the analogy that I like using. So we go from freeways to surface streets to neighborhood streets, back to surface streets, back to the freeway. We have something called our hematocrit. The hematocrit is the composition of what is in our blood. We have red blood cells, we have white blood cells, we have platelets, and we have plasma. Our red blood cells do what for us? Carry oxygen, right? It carries oxygen and nutrients into my body, and it carries waste and byproducts out of my body so I can get out of my system. My white blood cells, these are used to fight infection. So these are my immune system designed to kill off anything that's trying to kill my body. My platelets, they create blood clots. And then I have my plasma. My plasma is the fluid that contains or carries all of the other products of blood throughout my body. The majority of my blood is composed of plasma. It's anywhere between it's anywhere between about 55% of my blood is my plasma. I have my red blood cells, which is about 42% of the contents of my blood. And then my platelets and my white blood cells consist of about 3% of my blood. Okay. So as far as my hematocrit, the majority of my blood consists of what? Plasma. And then my red blood cells do what for my body? Carry oxygen and nutrients. What do my white blood cells do? Fight off infection. They're my immune system. They're what protects my body. And then my platelets do what? They clot. So if I cut myself, my scab, that's platelet. Okay. So that's what stops my body from bleeding naturally. As far as circulation, I have my pulse and my blood pressure. My pulse is when my left ventricle contracts and sends a wave of blood through my arteries. Where are some places that I can feel for a pulse? What was that? Yeah, my wrist or my radial. What is this one called in my neck? My carotid. What is this one in my arm? What is this one? We already talked about this one. What's this one in my pelvis? My femoral. Okay. Does anyone remember the behind my knee one? Popliteal, right? Did you look at that? No? Nice guess. Nice guess, Bus. And then I have my posterior tibia, which is behind my tibia. And then I have my pedal pulses, which are on top of my foot. Okay, so all of the places where I can check a pulse, those are arteries. And that's that wave being sent through our body, right? Then I have my blood pressures, the force exerted on the interior walls of my vessels during contraction and relaxation. Okay, I have my systolic blood pressure and my diastolic blood pressure. What is my systolic blood pressure measuring? The contraction of my left ventricle, right? And then what is my diastolic measuring? My heart at relaxation, or my heart's not contracting. Okay, so that contraction is my systolic, that relaxation is my diastolic. As far as perfusion goes, this is the delivery of oxygen, glucose,